Good evening, everyone. Thank you all for joining. It's my privilege to introduce our esteemed mentor, Dr. Nagarathnamma. She is highly experienced in the field of OBG. She is currently in the position of Professor of the Unit 2 in the OBG department. She was the ex HOD of Rrmch and she was the ex president of Bangalore Society of Obstetrics and Gynecology. She had got a lot of achievements. She did her M.B.B.S in Bangalore Medical College and Research Institute and MD in Kempegowda Institute of Medical Science. She was president of BSOG in 2019 and 2020, chairperson Breast Committee Kasoga, member of Foxy Breast Committee, South Zone Coordinator Breast Committee Foxy, Honorable Secretary of Bangalore Menopause Society, EC member of KSA AGIOI, member of Board of PG students at Rajiv Gandhi University from 2018 to 2021, treasurer of Bangalore Menopause Society, has been orator, speaker in many renowned state and national and international conferences. She had got Best Teacher Award, Doctors Day Award, IMA Teacher Award, Foxy Achievers Award, Distinguished Teacher Award from BSOG.
Student presenting is Sharanya. She is final year student, Rajeshwari Medical College. Over to you.
Kind introduction, and I am thankful to you for having invited me to be the mentor for this case discussion on previous cesarean section, which is an important topic for both undergraduates as well as for the postgraduate students. And also, I would like to thank Miss Sharanya, our final year undergraduate student, for presenting this case on previous cesarean section.
Is the 29-year-old Mrs. ABC, which works as a software engineer. She's been married for 5 years to Mr. XYZ, age 32 years, who also works as a software engineer. They have a non-consanguineous marriage. Her previous menstrual history, she attained menarche at 13 years, had regular cycles which were of 28 to 30 days duration with 3 to 5 days of bleeding. And she changed her pads 2 to 3 times a day, and there were no history of clots or dysmenorrhea. Chief complaints. She came with 9 months of amenorrhea for regular antenatal checkup. Her obstetric history. Her obstetric score is Gravida 2, Para 1, Living 1. First pregnancy was a male child, 3 years of age. He was full-term elective lower segment cesarean section for breech presentation. There were no antenatal, intranatal, or postnatal complications. He weighed 3.3 kgs at birth and is currently alive and healthy. Present pregnancy. Last menstrual period was on 11th February 2024. Estimated date of delivery is 17th November 2024 as calculated by the Negre's formula. Current period of gestation is 38 plus 2 weeks. First trimester, she had a spontaneous pregnancy, which was diagnosed by UPT at 1.5 months of amenorrhea and was confirmed by ultrasound at 8 weeks, which was also a dating scan. NT scan was done at 13 weeks period of gestation and was normal. Folic acid supplements were taken for 3 months. She had on and off morning sickness, which was treated with antiemetics. No history of bleeding PV, fever with rash, or drug intake. There was no history of exposure to radiation. Second trimester, quickening was felt at 5th month. Iron and calcium supplements were taken. 2 doses of TT vaccination were given. Anomaly scan was done at 20 weeks period of gestation and it was normal. At 26 weeks, OGCT was done and it was normal. There is no history of bleeding PV, headache, blurry vision, abdominal pain at scar site. Third trimester, she is appreciating fetal movements well, continuing iron and calcium supplements. Growth scan was done at 30 weeks period of gestation and is normal. There is no history of bleeding PV, abdominal pain, headache, blurry vision, leak per vagina, and fetal edema. Past history. She is not a known case of diabetes, epilepsy, tuberculosis, renal, cardiac, or thyroid disorders. There is no past surgeries or hospitalization. Family history. There is no history of twins, hypertensive disorders of pregnancy, diabetes, congenital anomalies, genital malignancy in the family. Personal history. Diet is mixed. She has adequate appetite, sound sleep, and regular frequency of bowel and bladder. She did not previously have any addictive habits of smoking or alcohol consumption.
I will Sharanya. You can go back to the first slide. We will have a discussion. Yeah, first slide here. So here you have put in the, for identification, the patient name, age of the patient, occupation, and married life. Okay. So now what is the importance of age? Just we'll brush through the basics of for this thing. So what are the importance of age in relation to obstetrics?
Ma'am, it matters when there's an extremities of age. Like if there's a teenage pregnancy, there's an increased chance of cephalopelvic disproportion, and there's more chance of instrumental delivery. In an older individual, like if they're more than 35 years, they can have pre-existing comorbidities like hypertension, diabetes, and they're also at more risk for congenital anomalies like Down syndrome and gestational diabetes.
Yeah. And what about the occupation?
Occupation, ma'am, if they work in a strenuous environment, they're more prone for miscarriages or abortion. They can also go into preterm labor in the third trimester, and they can also have the baby can have IUGR.
Yeah, especially if here it is a software engineer, but still they also can go in for preterm labor IUGR, but more with a, in case of coolies who have very strenuous work. So they can have abortion, repeated abortions, IUGR, and preterm labor, PROM, all those things are very common. Again, malnutrition, anemia is very common in the low socioeconomic group compared to the higher class people. And here in the patient details, you have missed out something. What is it? Socioeconomic status. Just now I told you. So as per the Prasad classification, you have to classify them as higher, upper middle, lower middle. The classification has to come, but because that is very important in the to know, rule out certain complications. Like I told you, low socioeconomic group, they are very prone to develop anemia, malnutrition, and higher class, they are prone to, because of the obesity and the other things, they are prone to develop hypertensive disorders. They are prone for GDM, the increased incidence of GDM, hypertension, other things are there. Okay, Sharanya. And what about the menstrual history? How important it is?
Ma'am, the regularity of the menstrual cycles are important because when we calculate estimated date of delivery, it gives some credibility to our date, and we can give an accurate date.
Yeah, if they are irregular?
Ma'am, if they're less than 28 days, then we have to subtract the number of days.
Okay. We have to depend on?
The dating scan.
What is the best way to, when we don't know the LMP, or if the periods are irregular, how can we establish the estimated expected date of delivery?
Ma'am, dating scan is the best method.
Yeah. So ultrasound estimation of CRL length in the first trimester, dating scan is done to know the period of gestation. Okay, next slide. So here, chief complaint, she doesn't have any complaints, but she has come with a history of amenorrhea of 9 months, and she has come for a regular antenatal checkup. In obstetric history, so you have, very important is your obstetric score. So here you have written gravida 2, para 1, living 1. Yeah, how important it is. Some basics. Suppose if she has, suppose if previously, if she has got a twin delivery, twin pregnancy, delivered twins. So what will be the obstetric score this time?
It will be gravida 2, para 1, living 2.
Living 2. So para doesn't change. So it is the number of pregnancies she has delivered, and gravida is the number of pregnancies including the present pregnancy. She has become pregnant including the present pregnancy. Okay. So now first pregnancy. Yeah. Can you elaborate on that?
Yes, ma'am. She had a male child 3 years ago and was delivered by elective lower segment cesarean section at full term.
Term. So why it is it important? How it is important?
Ma'am, now
Most
she's come
important
for
us
us as a
here
case of
during this
previous one
pregnancy.
LSCS.
Huh?
She's
How
come to
important
us
it
as
is.
a case of previous one LSCS.
Okay.
So the term becomes important, ma'am, because if there's preterm, then
Suppose
the
if it were
integrity
to
of
be a preterm delivery, for some reasons for PRYM or some other like associated comorbidities like hypertensive disorders of pregnancy, she has had a cesarean section at preterm. Then how is it? Does it differ?
Yes, ma'am, because the integrity of the scar will be little compromised
In
in
preterm.
preterm if the preterm delivery.
Yeah, because the scar will be most of the time lower segment is not well formed. So naturally it will be, we will take incision in a almost upper segment, lower part of the upper segment. So the thickness of the myometrium is very thick, and so the approximation of the edges may not be that appropriate. So there will be gutter formation. Naturally, the scar will be weakened. Okay. Then indication here is a breach. Does it matter?
Yes, ma'am. Breach is not a recurring presentation. So we can try. We can try for trial of labor this time.
And what about, can you just list out the common indications for cesarean section?
Yes, ma'am. There are some absolute and relative indications. So absolute would be like central placental previa or cephalopelvic disproportion, or if there's an outlet obstruction like fibroid or carcinoma. And there are some relative indications like failed induction or fetal distress, malpresentation like breech,
Yeah.
and also previous cesarean section.
Previous, not one cesarean, previous two, especially the classical cesarean section. Classical cesarean section is a one thing we have to think of. Cesarean section, okay. Then what about this one? She has got a male child which is 3 years old. How does that matter?
Ma'am, because the inter-pregnancy interval becomes important here. If
Is
it's
it
less than
inter-pregnancy or
18
inter-delivery interval?
inter-delivery,
Yeah, inter-delivery. What should be the inter-delivery interval?
it should be more than 6 months.
As per
It
the
should be more than 6
recommendations, RCOG or ACOG, what is the NICE guidelines? What does it say? Inter-delivery interval should be
more than 6 months.
18 months. Okay, inter-delivery interval should be more than 18 months. Okay, then the integrity of the scar. So you would have given a good time for the scar healing. So naturally, the integrity of the scar will be good. Okay. What about the birth weight?
Birth weight, ma'am, this comes under the normal range of birth weight.
So average birth weight. This is a average birth weight for this thing. So this pregnancy we have to see, assess the pelvis for this pregnancy. Okay, continue. Next slide. Okay, here. Tell me. How important is this LMP-EDD? So that's already we have discussed that how to calculate the expected date of delivery from the LMP, provided you should have written there, provided her previous menstrual cycles are regular, 28 to 30 days cycle. Otherwise, it becomes difficult for us to rely upon the EDD. Then we may have to rely upon our dating scan, first trimester dating scan. This is a history of present pregnancy, no? So for this one, first trimester. Okay, she had no complications in the first trimester. She is the case of, she is well booked. What do you mean by well booked? Hello, Sharanya?
Yes, ma'am.
Yes. What do you mean by well booked? So she is, because it was a spontaneous conception, and also in the first trimester itself, she has come to the hospital for confirming her diagnosis, and also she had a dating scan and also NT scan, and she has taken folic acid supplementation. So then we have to call this as a booked case. So as per the WHO, What do you mean by booked case and what do you mean by unbooked?
Ma'am, if they're going for regular antenatal checkups at the same place,
How
and
many
if
visits
they
as
have
per WHO? Minimum?
WHO recommends 8, ma'am, but in India we follow 4 or 5.
5 visits at least. In that, at least one should be in each trimester. One should be in each
Yes.
trimester. And also she should have had this one, during this visit, she should have had one anomaly scan. She should have been immunized with 2 doses of tetanus toxoid. Okay, then only we can call that as a book. That is the purpose of booking, to identify any high risk factors in this pregnancy and to treat them accordingly. Okay. So, and here you have written NT scan done at 13 weeks. What is the period of gestation where you can, up to what gestational age you can do the NT scan?
Ma'am, we can do it from 11 weeks to 13 plus 6 weeks.
Why should you do this NT scan?
It's a screening tool for chromosomal aneuploidies, ma'am. So
What are the things aneuploidies you can screen by doing NT?
Ma'am, we can check for trisomy 21, that's Down syndrome, trisomy 13 for Patau, or and trisomy 18 or Edwards syndrome.
Okay. And what is the detection rate by just doing an NT alone?
Ma'am, 85% of these chromosomal aneuploidies can be detected.
Okay. So can you combine with some other things? So can you do a combined screen, first trimester screening?
Yes, ma'am. We can.
What is
we
it?
can do a double marker test. That's biochemical serological markers for PAPI and pre-beta HCG. That'll increase the detection rate to 95%.
Okay. Okay. Then if that comes as if it's low risk, there is no need to further evaluate. You can straight away go with the anomaly scan. But if that comes as a intermediate risk or a high risk, then probably you have to give the counsel the woman for the option of NIPT or the going in for amniocentesis and karyotyping, especially if she has got she's a case of high risk pregnancy where previous anencephaly or previous neural tube defects. So then it's better, or previous history of Downs, it's always better to confirm it by amniocentesis and karyotyping. Otherwise, like only the risk factor is only intermediate risk and the age is not there are no other risk factors, then probably we can do with the NIPT. And if that comes normal, you can straight away go with the anomaly scan. Okay, next. Yeah. So in this, you're written, so she had some emesis gravidarum and there was no history of bleeding, fever, okay, rash. Okay, quickening is felt. Why should you know about the quickening? Earlier, we used to give a lot of importance for quickening.
Ma'am, it's a sign of like if the fetus is alive and healthy.
Okay. And secondly, we used to calculate the expected date of delivery before the era of ultrasound. We used to calculate the expected date of delivery in case she doesn't remember her LMP from the date of quickening. So in a multi, we add 24 weeks. In a primi, we add 22 weeks for calculation of expected date of delivery. Okay. So she has been well booked because 2 doses of TT has been given. We have done an anomaly scan at 20 weeks. Okay. What is this one? What is the ideal period of gestation to do an anomaly scan?
Ma'am, it can be done between 18 to 20 weeks.
20 weeks. And again, suppose if there is any problem with this, then suppose if she is a case of previous baby having a cardiac problem, then
we can do again 24 weeks, then the cardiac
22 to 24 weeks we can, because the cardiac assessment can be done well between 22 to 24 weeks. So that time we can do a repeat scan in a high risk woman. Okay. So you have written here OGCT done at 26 weeks. So what is OGCT?
And it's a screening tool for gestational diabetes.
Okay.
We have to do it
How
at least
often we
once
have to do in
trimester.
pregnancy?
We have to do in all the trimesters.
Okay.
So when we do it in the
How do
first
you do?
trimester, like the first visit, now we have to give 75 grams of glucose in 100 ml of water. And then we have to ask the patient to drink it
200
within
ml,
10 to
200
15
to 250 ml of water with a little lime
lime.
squeezed into it, and then she has
We
to
have to ask
consume
the
within
patient to drink it.
5 to 10 minutes, and then get her plasma glucose after 2 hours. And this is with irrespective of her last meal. So she need not come on a fasting stage. This is a DIPSI method, which is a one-step method of oral glucose challenge test. So where we do it irrespective of the meal, you give her 75 grams of glucose dissolved into 250 ml of water with a little lime squeezed in it so that it is palatable. And she has to consume within 5 to 10 minutes. And then draw the blood after 2 hours, and the cutoff should be less than 140 milligram per deciliter. Okay. If it is more than 140 and within 200, then how do you treat her?
Ma'am, we have to go for diet management and exercise.
Medical nutrition therapy, that is known as MNT. For 52 weeks, you advise her on medical nutrition therapy along with diet and the diet and exercise. Okay, so then you have to repeat fasting and postprandial sugar. If that is normal, then probably she can continue with MNT. If it is not under control, probably you may have to go with a oral hypoglycemic agent, or maybe if it is more than 200, definitely she is the candidate for insulin therapy. Clear? And suppose if this is normal in second trimester, when will you do next?
Ma'am, in the third trimester, we can do between 32 to 34 weeks.
34 weeks of gestation. Okay, fine. And you have written here, no history of bleeding, PV, headache, blurring of vision, abdominal pain. What does it indicate? Why should you ask this negative history?
Ma'am, these are symptoms of impending eclampsia.
Warning signs. You are supposed to counsel the patient regarding the warning signs of impending eclampsia. And if she experiences any one of this, she has to report immediately, not wait till her next date of checkup. Next visit. Okay. Okay, fine. Next. Yeah, continue.
Third trimester, she's appreciating fetal movements well, continuing at calcium supplement.
Okay. Next. Okay, next. Yeah, general physical examination.
Patient is moderately built and nourished, conscious, cooperative, and oriented to time, place, and person. There is no signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vitals. Pulse is 82 beats per minute, regular rhythm, normal in character, and there's no radioradial or radiofemoral delay. Blood pressure is 130 by 84 millimeters of mercury, measured in the right arm in sitting position. Respiratory rate is 17 cycles per minute and is thoraco-abdominal type. She is age 65. Height is 160 centimeters. Pre-pregnancy weight is 52 kg and current weight is 60 kg. BMI is 20.3 kg.
Okay. So you have taken the height. What is the importance of height in an obstetrics? Why should you know the height?
If she's a short stature woman that's less than 145 centimeters, it can be associated with contracted pelvis or cephalopelvic disproportion.
Okay. And what about this weight? You said 52 pre-pregnancy and then 60 kgs. How much of increase she has had here?
8 kgs.
8 kgs only. What is the ideal weight gain during pregnancy?
9 to 12 kg.
Almost 10 to 12 kgs she can put on weight. 1 kg per this one. Yeah, 10 to 11 kgs. So 1 kg per month she can put on weight. Suppose if there is a sudden increase in the weight gain, so what should you, how should be you cautious?
Ma'am, she can be developing preeclampsia. So you have to look out for
Because of the water logging and other things. So you have to be careful and monitor her BP very closely. Okay, next. Systemic examination.
systemic
No comment.
examination.
Okay, fine.
For abdomen,
Mm.
instruction, patient is in supine position with knees extended and is exposed from sternum to pubic symphysis. Abdomen is uniformly distended, flanks are full. Umbilicus is central and inverted. All quadrants move equally with respiration. There is presence of stria gravidarum and linea nigra. Previous LSCS scar is present, that is through a phenolphthalein incision, which is healthy and has healed by primary intention. There are no other scars present. There are no dilated veins or sinuses, and hernial orifices are intact.
Okay.
Palpation. Patient is in supine position with knees flexed.
Semi-flexed, not totally, semi-flexed. Mm.
Okay. Uterus is relaxed. Height is at 34 to 36 weeks. Symphyso-fundal height is 32 centimeters and abdominal girth is 30 centimeters. Next are the grips. So fundal grip, there is a round, smooth, irregular part which is suggestive of breech. Left lateral grip, we can feel smooth, continuous curvilinear part suggestive of spine. Right lateral grip, multiple knob-like structures are felt suggestive of fetal extremities. First pelvic grip, there is a hard globular bellotable mass suggestive of fetal head, and in the second pelvic grip, our hands are convergent. Scar tenderness is absent. The liquor appears adequate, and estimated fetal weight by Johnson's formula is 3.1 kgs.
Okay, here you have written the pelvic grip, no? Hard globular bellotable mass. For this undergraduates, you have to do this, but for postgraduate, you can write it as a singleton fetus with a cephalic presentation with a mobile head because it is bellotable. Hands are converging. What does it mean?
Ma'am, it means that the head hasn't engaged into the pelvis yet.
It has not it. So because that's the reason why it is bellotable. Okay. So how do you suppose if it is engaged? I mean, if the hands are diverging, what is the inference?
Ma'am, that the head has engaged.
Hmm?
The parietal diameter has reached into
Okay.
the pelvic development.
Why is this second pelvic grip important?
Ma'am, it tells about the engagement of the head.
Okay. And also? What do you palpate?
It tells the presenting part also.
Presenting part, okay. Bellotable, globular, that's also tells about the attitude of the fetal head, the fifth formula. So we'll tell you about the attitude. What are the two bony points that you palpate there in the second pelvic grip if the head is getting in? If the hands are diverging, so the head is getting into the pelvic brim. So what does it? What are the two bony points you palpate? To know the attitude of the head. So you palpate two bony points.
Occiput and sinciput.
Yeah, one is occiput, other one is a sinciput. So when do you say that the head is reflexed?
If the sinciput is felt.
Sinciput is felt is what? Only one pole is palpable is what? The head is engaged and it has gone in. So the attitude will be flexion. If the occiput and the sinciput are in the same line, then it is deflection. Got it? Occiput,
Yes,
see, in a well-flexed head, it is the biparietal, the suboccipital-bregmatic diameter gets engaged. Okay, which is 9.5. So that has, in a well-flexed head, that gets into the pelvic brim. It passes through the pelvic brim. So then only the sinciput is palpable. Occiput has gone in. Is it clear? So that then you are going to palpate only the one pole is the sinciput. So that is a well-flexed head. Okay. And you have written there the, hello?
Yes, ma'am.
You have written there the no scar tenderness.
Yes, ma'am.
Yeah. How do you identify the scar tenderness? How do you check for scar tenderness?
Ma'am, we have to do deep palpation over the lower uterine segment scar. So that's in the
Where do you look for
suprapubic
that?
region.
That you have to describe. Where will you look for? Suppose if you have a skin incision, a vertical incision.
Ma'am, we have to palpate in the suprapubic region. That's 2 centimeters above the pubic symphysis.
Just behind the upper border of the symphysis pubis will be your lower uterine segment scar. So there you have to palpate. How do you palpate?
Ma'am, we have to divert the attention of the patient.
Yeah, you better
And
ask her about that because she will be very anxious. I mean, happy to tell about her previous child. So you ask her what is the name of the child, what it is doing, which class it is. Is she are going to the class? Then you keep palpating from one end. Start from one end of the scar and slowly you have to put in little pressure and palpate the whole distance of the scar. Okay, and then you have to divert her mind, see whether she is going to wince when you are palpating. If she is going to wince and then is feeling discomfort, then you must suspect scar tenderness. And is it only the scar tenderness? What are the other things that you can rule out? You have to rule out.
if there's any uterine rupture.
Huh? Uterine rupture during antenatal? Which cases will rupture during antenatal period, during pregnancy, especially in the last trimester? Which type of cesarean section does a rupture is more common in the antenatal
Classical
period?
cesarean.
Huh? Classical
Classical
cesarean
cesarean.
section, or if she has had a previous myometrial scar where the cavity is opened. But now there is a controversy regarding that. Even if the cavity is opened, they say the rupture is it doesn't rupture. But anyway, that we have to see. Okay. So here she has had a lower segment cesarean section. Most of the time it is only during lower segment will the incidence of rupture is common in during
Ma'am, it can be during labor.
labor.
It will be very
During labor, when she comes in with labor pains, the chances of cesarean rupture is quite. What is the percentage? Lower
Ma'am, if
segment
it's
cesarean scar rupture?
lower transverse is 0.5 to 1%.
1%, yeah. And that is 1 in 200. That is 0.5 is 1 in 200 pregnancies. Because this is very important while counseling the patient when you want to plan for a TOLAC. Okay. And what about this one? In classical cesarean section, where it can happen
4 to
in the
9%.
last trimester, late last trimester, as well as in the during labor. What is
Yes,
the rupture incidence?
4 to 9%.
No, not that high. Yeah? 2 to 3%. Okay. So that's one thing. What are the other things you can observe? So it may be scar tenderness, maybe due to dehiscence, or maybe due to any
Cystitis
other
or
causes
adhesion.
for pain or wincing.
There can be cystitis, ma'am, or the
Yeah. So
adhesion.
bladder. So the bladder is front of the uterus there. So you can, while if she has cystitis, definitely when you try to palpate, she can have a tenderness. Then what are the other organs there surrounding? Hmm?
Now, there are adhesions formed
Yeah,
after the period.
additions. So additions may be there. So because previous cesarean section, there will be definitely some additions will be there. That additions also will be pulling, especially so there would have been some advancement of the bladder and some the thing will be there, additions. So they also might, because of the stretch, once the lower segment getting formed, so there will be a stretch on the lower uterine segment. So that can give rise, the additions can give rise to pain abdomen. And rarely non-obstetric cause will be non-obstetric.
Fibroids.
Okay, degeneration in a fibroid. That is obstetric. Degeneration, any changes, degenerative changes in a fibroid. What is that degeneration known as during
Red degeneration.
red degeneration? She can have a pain. Again, our neighbor. Any surgical problem?
Ma'am,
Appendicitis.
appendicitis.
Appendicitis, colitis. These are some of the causes for pain in the lower segment when you palpate. Okay. Okay. Next.
On auscultation, fetal heart sound is present in the left spino-umbilical line,
Okay.
regular rhythm, 142 beats per minute.
Next. We'll go with the discussion. So summary. Okay.
So, yeah. To summarize the case, it is a 29-year-old Radha 2 Paravan living one woman with a 38 plus 2 weeks period of gestation, a singleton pregnancy with cephalic presentation with one previous LSCS 3 years ago for breech presentation. There is no obstetric complications or comorbidities, and she is not in labor.
Okay. Now, so now what is your next this thing? Would you like to admit her or would you like to admit her?
Yes, ma'am. She is term pregnancy, so we can admit her now and talk to her about her option.
So she is a case of previous lower segment cesarean section. So we have to admit them at 38 weeks. Suppose if she had a classical cesarean section because of central placenta previa, some problems, then
Ma'am, then at 36th week we have to admit.
yeah. So if it is a classical cesarean or previous scarred uterus, then probably we have to admit her much early, 36 weeks only. We have to admit her and then plan for. In case of classical cesarean section, what is the mode of management?
We have to do repeat cesarean.
Yeah, it's always better to go with a repeat cesarean section because the incidence of scar rupture there is very high. So when will you do in such cases? We have to admit her at 36 weeks. Yes. But when will you do the C-section? 36 weeks only?
No, ma'am. We'll wait till 38.
38 is the gestational age where we have to do the cesarean section. So, but only thing if she develops some signs of impending rupture or something, then probably, or if she gets into labor, immediately we can do. Otherwise, ideally, a repeat section, as an elective repeat section, it has to be done at 38 weeks. So these are the investigations you would like to do. Yeah, yes, these are the basic investigations we do in all antenatal women. So, and also again, term ultrasound, to know the fetal weight, Leica volume, and also you have written uterine scar thickness. How useful is this? Yes. What should be the, why should you know about the uterine scar thickness? Ultrasound.
Ma'am, if we can, it should be more than 4 centimeters. Then only we can.
Not 4 centimeters, 4 millimeter. 4 millimeter, sorry. It is 4 millimeter thickness. Huh?
Yes, sorry.
So it indicates a good integrity. If the scar thickness is more than 4 millimeter, indicates a good integrity of scar. But anyway, this alone, we cannot take this alone because there are not much evidence, but we can not go by only the ultrasound finding. So we have to look into the historical history. What was the indication for cesarean section? Okay. What was the previous indication for cesarean section? How does it help? Was it a recurrent indication? I mean, it was done as an elective or as an emergency? Is it a term or preterm? Or it is did she have a prolonged labor and a section done in the second stage of labor, or she has come with a history of PROM? So those are the ones which that history is very, very important to look for the integrity of the scar. Okay, got it?
Yes.
Already we discussed that preterm, the scar thickness, the scar integrity of the scar will be poor. Similarly, if you take her in during the second stage of labor, when already the cervix is fully dilated, you have waited for 1 or 2 hours, the head is not coming, you have given an episiotomy, tried a vacuum forceps, still it's not. Then when you have done all that circus, naturally the lower segment would have stretched and the scar will be weakened and it will be prone for infection. So that scar integrity is definitely poor. So that is the reason why you should have a good history during especially the previous cesarean section. You must elicit a good history, and if you can get her the discharge summary, it's always better, especially during the cesarean section. What was the difficulty they had, especially in case of second stage of labor. Second stage of labor, if you have taken, what can happen? Jammed head. When you are taking out a jammed head during a cesarean, what can happen? There will be angle extensions, and also it can the incision can extend vertically or lower down, involving the bladder. So if that is done naturally, the scar will be, so if it is extended to the angles, so there will be uterines will be involved, and you would have taken a stitch there to arrest the bleeding. So once you have done a suturing of the uterines, naturally the blood supply to that part is to certain extent until it develops a collateral circulation. So they'll be impeded. So naturally the blood circulation, naturally it will be, the healing of the scar is disturbed. Okay.
Yes, ma'am.
Yeah. Now, how are you? Now, what is the plan of this thing? She's already 38 weeks. Would you like to do a repeat section, or would you like to give her a TOLAC?
Ma'am, we have to discuss with the patient about what she wants, but we can suggest TOLAC for her.
TOLAC.
Because
So what are the criteria to give TOLAC?
Singleton pregnancy with cephalic presentation. There should be no comorbidities. There should be like only one previous cesarean section. And the indication for the cesarean should be a non-recurring one. So
here in this case, it's a singleton fetus, average size baby, less than the previous, and also it was for a breech presentation, which is a non-recurring indication. Okay. And it was done as an elective section at term. It was a term. So naturally, the criteria it fulfills. Only thing this time, since it is a breech presentation, you got to rule out in this, you got to assess the pelvis and rule out CPD.
Yes, ma'am.
Yeah, once you have ruled out CPD and the average size fetus and the pelvis is adequate, you can explain her regarding the what are the risks. You can discuss regarding the benefits and risks of TOLAC leading to VBAC. And also suppose if it is a repeat section, what are the risks involved in that? Okay. What are the risk factors if you give a TOLAC? What are the benefits of TOLAC?
Benefits would be like in our next pregnancy, we can try vaginal delivery, and there's reduced maternal mortality if there's VBAC. And there's lesser need for blood transfusion, or length of hospital stay is also reduced.
And then?
And the complications.
Comorbidities. So because whenever you give a next pregnancy, again she can have a repeat cesarean section, and again there will be placental issues like placenta previa, accreta, all those things. Then she may land up with hysterectomy, peripartum hysterectomy, all those things are there. But again, the disadvantages of TOLAC is she may
there can be wound dehiscence or uterine rupture.
Scar rupture or dehiscence. So we may have to take her up for cesarean section, repeat cesarean section. There may be need for blood transfusion, and
mortality is also increased. And for the fetus, there can be low APGAR score. Or
no. The mortality with this thing immediately anyway. It should be in a well equipped, in a tertiary care center. It should be so mandatorily it would be a hospital delivery, especially a tertiary care center where all facilities for blood transfusion, OT, and neonatologist and anesthetist ICU facilities are available. So there we have to give a try for a VBAC, TOLAC. Okay. So if TOLAC is successful, then she can have she is a vaginal birth after C-section. Okay. How will you monitor? Suppose if you have given her, she accepts for TOLAC. How will you monitor in labor? Manage her in labor?
Ma'am, we have to use the labor care guide. in which the vitals of the mother, like pulse, blood pressure, urine output, all of those are monitored, and also whatever drugs we give to the mother is registered in that. And we can
Okay.
also do continuous CTG monitoring for the fetus to detect any
Electronic
distress.
fetal monitoring should be done. Yeah.
Yes.
And then also check for the
Contraction.
scar.
Yes.
Scar tenderness. You have to look for the scar tenderness. And during labor, how do you check the scar tenderness?
We have to do it between contractions.
Contractions in a relaxed, when the uterus is relaxed. So that time you have to check for the contractions. So how do you know that there is a scar dehiscence or rupture?
Ma'am, the contractions would have stopped, like this, it would have ceased. If the scar is
there is a difference. What is the difference between dehiscence and rupture?
Ma'am, dehiscence is when there is separation of the scar, but the peritoneum is not involved. And rupture is when all the layers of the scar are involved.
Yeah, first what? So in a dehiscence or rupture, what is the first thing that involves? What will give way?
Bradycardia.
No. Myometrium. Myometrium is the first one to give way. Then you have the serosal layer. Then you have the amniotic membrane behind. So 3 layers. So the first thing is the myometrium will give way. The serosa will be intact. Okay. Yes. So that is in a scar dehiscence. Whereas in scar rupture, all the 3 layers would have been given way. Okay.
Yes.
And also in a rupture, suppose if it is total rupture, then probably the contour of the uterus would have been lost. There will be bradycardia or variable deceleration or late decelerations of the fetal heart rate. And again, there will be
maternal tachycardia and signs of shock.
Maternal tachycardia, hypotension, and again, she may be in shock. So these are the signs of rupture, and then vaginal bleeding will be there. So there will be vaginal bleeding. Okay. So how will you then what about the PV findings? PV findings.
Ma'am, for dehiscence?
PV findings. What will be the findings in case of rupture?
Ma'am, there'll be abnormal bleeding and loss of station of the presenting part.
Presenting part would have receded up, and the cervix will be the well applied the fetal head would have been well applied over the cervix. So because of the rupture, so the head would have receded and the cervix will be loose hanging. Okay. Or sometimes even the presenting part will be lost if it has ruptured badly and it has gone into the abdominal cavity. Okay.
Yes, ma'am.
Okay. So now, suppose if, successfully she's, there is no scar tenderness, the labor is progressing well. So first stage you are monitored, there is no problem with this thing. And one more thing is, what are the prerequisites when you give a VBAC? What are the prerequisites?
Ma'am, we treat it like a normal labor, how we would. So we have to admit the patient, give her an enema, and she has to be nil for oral. And we give IV line for fluids. And we have to also
you should keep her nil orally. First and foremost is informed consent. You have to explain her all the risks and benefits of giving a TOLAC, and she should agree to all this. So that is known as an informed consent. Everything should be explained to her in her own language, and you should take her signature and 2 witnesses for that. And then only when she agrees with all that, then you can give a TOLAC. And once she agrees for TOLAC, you got to arrange for blood for cross-matching and keep it. Okay. And all the OT, anesthesia, the neonatologist should be well informed, and you should keep her nil orally and give only the maintain IV line. Okay. And then continuous electronic fetal monitoring should be done. And labor care guide should be plotted to know the progress. Okay. If she's progressing well, so first stage you have to monitor this, and later, second stage, she is now full
Try to cut it short, ma'am. Second stage.
Yeah, so you
So
don't
it is
want unnecessary
oxytocin.
pressure on the previous scar. So you got to cut short the second stage of labor by vacuum
We
or
give
forceps
oxytocin.
delivery. Ideally will be forceps delivery is ideal because there you don't require her to bear down. Whereas vacuum, we sometimes ask her to bear down. Okay. So vacuum or forceps delivery we can do. Then the third stage management is as usual. And then next, would you like, what else will you do? Once the placenta has come out, the uterus is well contracted. Would you like to explore the scar?
Yes, ma'am.
Yes, sir. There is a controversy regarding this. Some people will advocate exploring the scar, but some say, suppose if there is any like a small dehiscence, so you'll be unnecessarily undoing that. So the scar exploration can be done only in cases of if there is excessive bleeding, if the patient condition is deteriorating where you can suspect some rupture. So in that situations, otherwise, if it is a well contracted uterus, her vitals are normal, bleeding is minimal, then no need for scar exploration. Is it clear?
Yes, ma'am.
Anything else? Would you like to know? Any questions? Any questions in the chat box?
No, ma'am, there are no questions.
Yeah, if you have no doubts, I think we'll finish with this. Okay.
Okay. Thank you.
Thank you all.